Hello friends, today we are going to discuss here about very high yield topic, that is pelvic fracture. This is important for ATLS and for saving of life, for NEET SS or NEET or for PGs also, NEET PGs. The incidence of pelvic fracture ranges from 15 to 20%, which around 10% will associated with bowel, bladder, urethral and vascular injuries. In bladder trauma, I explain there is extraperitoneal injuries most commonly associated with pelvic fracture. In urethral injuries, posterior urethra injuries. Okay, posterior urethra part includes, which I explain, like bulbar and penile urethra. One of the most dreaded presentation of pelvic fracture is hemorrhagic shock due to large amount of blood loss. Okay, dreaded means dangerous presentation. Pelvis is a large cavity and severe pelvic fracture can bleed massively, accumulating 2.5 liter of blood after bleeding. Very huge blood, 50% of body volume. Young Burgess classification, I'm going to explain here. Total two classification for pelvic fracture: Tiles classification and Burgess. So Young Burgess is the best. Total four types of pelvic fracture: anterior posterior compression fracture, lateral compression fracture. I am going to explain all type of fractures in pelvis with diagram presentation. Vertical shear fracture and combined fracture means combination of all three. Vertical shear fracture are most severe and unstable type with high amount of blood loss. Lateral compression fractures are often associated with bowel injuries, while anterior posterior injuries are associated with bowel, bladder and vascular injuries. The management of hemodynamic unstable fracture is based on ATLS principle. Hemodynamic unstable means patient in a shock. Okay, pelvic binder should be applied in emergency department if unstable pelvic fractures are seen. If the patient is not stabilized, then the patient is shifted to OT, operation theater. Pelvic bleeding is from three sides. If you find pelvic fracture, you notice three side bleeding: venous bleeding. How to control? By periperitoneal pelvic packing. Do pre-peritoneal pelvic packing. In bony bleeding, controlled by mechanical stabilization like external fixator. External fixator. And atrial bleeding is controlled by bilateral internal iliac artery ligation or by angioembolization if facilities are available. Let's see all three type of fracture, all fractures which I explained with diagrammatic presentation. Type 1 is anterior posterior, three type. Type 1, when pubic diastasis fracture or pubic symphysis opening, and in type 2, pubic symphysis opening, diastasis opening, and you find here the wing of wing of iliac bone is fracture or opening. Wing of iliac bone opening in anterior and posterior side, and pubic diastasis opening. So this is anterior posterior compression. Three injuries are most commonly organ involved: bowel, bladder. Okay, these are involved, which I explain. Vascular injuries and lateral compression involve bowel injuries. Type 1, when there is superior and inferior pubic rami fracture, and also iliac fracture here, wing fracture we can say. And in type 3, lateral compression, you find both side fracture of superior and inferior rami with iliac fracture. And in vertical shear, there is a complete fracture of one-sided, okay, pelvis, and another one is combined. Now, how to deal with pelvic trauma? This table is very important. If patient is hemodynamically stable, means no shock, do CCT torso. If unstable, then circumferential pelvic compression device, massive hemorrhage protocol plus minus tranexamic acid. So I am going to explain one more video about massive hemorrhage protocol and tranexamic acid use. Okay, how to use. Then stabilized. If yes, then CT torso after doing this massive hemorrhage protocol, transfusion or tranexamic acid use. If not stabilized, then periperitoneal pelvic packing is for what? For venous use. And bilateral internal iliac artery ligation or angioembolization is done for atrial bleeding. And pelvic external fixator or circumferential pelvic compression is for bony bleeding. So it should be kept in mind that no attempt should be made to diagnose the source of bleeding while treating a non-responder pelvic fracture. Non-responder is unstable patient. And all three modalities should be used simultaneously without exception. If patient is unstable, you can use all three modalities: peri-pelvic packing, peri-peritoneal packing, and you can go with external fixators, and you can apply internal iliac artery ligation or embolization if required in non-responder pelvic fracture patient. Despite advances in management protocols, the mortality rate remains high, 33% in hemodynamically unstable pelvic fractures. If the fracture is associated with open wound, then mortality may goes as high as up 50%. Means if two patients with pelvic fracture with open wound, then unstable, then only one will survive. So this is the probability. So guys, I hope this video is clear. If you like this video, put like on it, do comment on this video if you have any queries, and do share this video with your friends, and do subscribe this channel if you like this video. For more such videos I'm going to put on trauma surgery and ATLS. Thank you.